everyone. My name is Yvonne Wirngo, and today I am delighted to share my DNP Quality Initiative project with you titled Reducing Mental Health Readmission Rates with a Focus on Social Determinants of Health. First, before we start, I would like to share a little bit about myself. I began my nursing career by obtaining my associate degree in nursing after working several years as a nurse's aide at a nursing facility. My goal to be the best and provide the best for my patients propelled me to obtain my doctorate degree, which I'm currently getting at Maryville with a specialty in psychiatry as a psych mental health nurse practitioner student. I've worked in varied specialty across the lifespan, and my current experience is at an inpatient behavioral hospital where I completed my quality initiative project. Right, I would like to introduce you to my community members. They played a tremendous job to ensure that this quality project was a success. Starting with my DNP chair, Dr. Teresa Galakatos, my community mentor, Carol Kennedy, and my second reader, Dr. Maria Snell. Their tremendous support and insight was very instrumental towards the success of this project. Also, not forgetting the rest of the faculty at Maryville University for their dedicated knowledge and time to ensure the success of this project. Thank you all. This slide, I'll provide a brief background on psych hospital readmission rates and the effects of social determinants of health in mental health care planning. Beginning with the first row, I would discuss psychiatric hospital readmission rates as a quality initiative indicator, effects of frequent readmissions on patients, families, the healthcare system, and also how lack of biopsychosocial approaches in mental health has contributed to these readmission rates. Psych hospital readmission rates are a quality indicator of proper quality care. 1 in 5 mental health patients return to the hospital within 30 days of discharge, with a 3.7% increased chance of hospital readmissions among the homeless population. Frequent readmissions are financially disruptive and affect the individual's ability to thrive in communities, their families, and the healthcare system. These readmission rates account for more than $26 billion per year in avoidable Medicare expenditures annually. Lack of biopsychosocial approaches in mental health to augment clinical approaches can affect health equity and patient outcomes. Most mental health care is focused on clinical interventions, omitting factors that trigger the patient's mental breakdown. Most patients are often discharged to the same environment that triggered their mental health issues without proper intervention. Our second row, I will focus on social determinants of health, led admissions and discharge process. I would also look at how focus on social factors affect patient care, and also adoption of evidence-based individualized social risk factors in mental health can alleviate these readmission rates. So the first question would be, what are these social determinants of health? These are social markers that identify where people live, work, their mode of transportation, and in other words, it describes their socio-economic status. Social determinants of health-led admission and discharge process is much needed but lacking in mental health, which has contributed in much ways to readmission rates. These social factors are essential data points that work efficiently to provide a possible point of care data that enhances an effective patient discharge process when integrated into patient care management. These social factors are vital to hospital readmissions because patients with low socioeconomic status, those living in disadvantaged neighborhoods subjected to homelessness, substance abuse, poverty, unemployment, and even lack of education, are at a higher risk of being readmitted. Therefore, adoption of evidence-based individualized social risk factors in mental health can change the healthcare approach and ensure hospitals with high readmission rates are not penalized by Medicare based on their patient load. Purpose and aims of my project will be discussed on this slide. The purpose of this DNP scholarly project was to reduce the rate of readmission by adult mental health inpatients between 18 to 55 within 30 days post-discharge. After working at this behavioral hospital, I realized that there was an alarming readmission rates post-discharge despite effective clinical interventions, with patients returning as soon as 8 hours post-discharge from this facility. This led to the need to determine the effective ways to reduce this readmission rate. The goal was to implement a safe, individualized, evidence-based, patient-centered care tool that focused on social determinants of health-led admission and discharge process at this behavioral facility. I looked at individualized social care needs such as housing, transportation, food, utility, and interpersonal safety provided upon admission, upon discharge to at-risk patients upon discharge to determine if these interventions would reduce the rate of readmission post-discharge from this facility. This slide, I will discuss the PICOT question of this project. This PICOT question is very relevant to the purpose of the project. It states that for adult mental health patients 18 to 55 years in the inpatient setting, how does screening for social needs using elements of the accountable health communities health-related social needs screening tool compared to standard usual care discharge planning impact 30-day readmission rates, which is the outcome of this project within the time limit. The rest of the project will try to answer this question. On this slide, I'll discuss the integrative literature review based on current knowledge relevant to the PICOT question. This literature review identified 3 themes relevant to the project's topic of interest. I'll discuss these themes simultaneously. The first theme identified from the literature review was social needs screening tools. Most of the studies reviewed concluded that social risk factors are substantially more prevalent than represented in electronic care records, downgrading their importance in determining risk factors that affect the patient's health. Most of the research data concluded that designing tools that incorporate physician notes into the discharge process, especially in mental health, may enable better identifiable factors that support positive outcomes. The second theme was a standard care discharge planning tool. This theme addressed with most of the studies reviewed pointed out a lack of existing models that incorporate social determinants of health information in their discharge planning, despite the urgent need to promote health equity in the health system. Hospital patients discharged with no homes or shelter have emergency readmission rates not explained by their health conditions. Therefore, most of the research indicated that the information highlights the need for a discharge planning process can address their health, housing, and social care needs to ensure clinical compliance and patient positive outcomes. And the third theme discussed on this literature review was reducing psychiatric readmission rates. Even though some productive models showed no significant improvement in reducing unnecessary readmissions, most of the research gathered added that social factors did not ameliorate the prediction among all patients. However, most of the studies concluded that adding individual and community level social determinants of health factors significantly improved the prediction for Medicare patients, patients who are 65 years or older, and patients with low economic status. Now, I'll take your attention to let's discuss the theoretical framework of this project. Utilize the Donabedian model as the standard approach for assessing the quality outcomes of this project. This model was conceptualized on the idea that structure, process, and outcomes are closely linked and determine outcomes of a project. I also added balancing as a measurement tool for evaluating the desired effects of this project. This conceptual model provides a framework for examining health services and evaluating quality of healthcare. Based on the literature review, most studies that utilized this model were very successful, and it was a motivating factor for its use. Slide, I will discuss the chronological ways used to carry out this project. The methodological process of this project was achieved without any delays. Once the setting was determined, which was an adult unit of a behavioral hospital located in the south central region of the United States, a needs assessment was conducted to determine the need for this project at this facility. This led to the IRB process. The IRB process included obtaining an IRB from Maryville. The facility did not have an IRB process, so I signed a HIPAA form from the facility to ensure that patient safety and confidentiality was going to be maintained throughout the project. The planning phase included the development of a social risk action plan tool from elements of the advanced health community screening tool. Also, I provided nursing education on the implementation of this social needs tool during discharge and admission planning process. And resources to ease community referrals were also provided to nurses. This project design was a retrospective chart review, and no patient contact was initiated. The next slide would discuss the inclusion and exclusion criteria of this process. Slide, I would like for you to look at a clear presentation of my inclusion criteria for this project. So charts that met my inclusion criteria were those of patients between 18 and 55. These patients had to have social risk factors that placed them at risk of readmissions. Also, I looked at patients that were seen post-intervention and those that received these social interventions post-discharge from this facility, as well as those whose readmission status put them at risk of being readmitted. Slide takes us to the exclusion criteria for this project. So charts that were excluded, that are excluded, that did not meet my inclusion criteria were those of patients younger than 18 or older than 55 years old. And if there was no documentation of a need for social risk assessment, the chart was not included. And also if the patient was discharged pre-intervention. Let's talk about data collection. The process of collecting data for this project was insightful. I will utilize descriptive statistics to describe the demographics of data collected for this project. I would use these data points: gender, race, marital status, level of education, and employment status to explain the demographics of data that I collected. Of all the charts reviewed, 50 charts met the inclusion criteria for this project and will comprise of my social risk group. Of all these patients sampled in the social risk group, over 50% of them were female at 60%, and 40% of the patients were male. None of the patients reported being non-binary. Uh, Majority of the patients were Caucasian, with only 30% being of other ethnicities. 70%, 72% of these patients were single, reported being single. 11% were divorced, and over 2% of the patients were married. Majority of the patients reported having a high school degree, over 78%, or being a high school dropout, with only 2% of the patients reported have a graduate degree. And over 78% of these patients sampled were unemployed, and 22 reported tentative employment status. A closer look at this chart will show you the demographic data of patients readmitted post-intervention in the social risk group. Out of the 50 sampled in this group, 9 patients were readmitted post-intervention in 30 days, and out of these 9, 8 of them were female and only 1 male was readmitted. Most readmitted patients post-intervention were white females who were single with a high school education but unemployed. For you to take a closer look at this table that I presents data sampled from the medical records of this facility that clearly shows readmission rates in 30, 60, and 90 days. A closer look at the fourth quarter of the fiscal year 2022, I utilized this data as my pre-intervention data for this project, and also the first quarter of the fiscal year 2022 was utilized as post-intervention data, comparing it to my social risk group. So the second quarter of the fiscal year was just added here, used as a control measure to determine the continuity of this project at this facility. The lower z-test for the difference of two proportions, a directional form of the chi-square, was used to determine the statistical difference between pre and post readmission data collected from the facility and the high-risk group. The null hypothesis stated that there was no difference in the proportion of readmission rates pre-nursing interventions to the proportion post-nursing interventions. And the alternate hypothesis stated that there was a difference in one direction. The level of measurement was nominal. Independent variables were pre and post intervention group, and the dependent variable was a yes or no if the patient was readmitted or not. Like for you to take a closer look at this table. This is a z-test statistical analysis that I did for my project using the sample data from the fourth quarter of the 2022 fiscal year at the facility and my at-risk group. The p-value yielded was 0.7147, which is greater than the significance level of 0.05. A p-value greater than 0.05 means that no effect was observed between these two samples. Table shows you the confidence interval which are used to determine a true change in ratio amongst these groups. The z-value is negative, and since 0 was included within the intervals, there was not sufficient evidence to show a change in one direction. And the achieved power of this study was 0.1525, which was considered low in strength. On this section, I will direct your attention to percentages of social interventions provided, patients readmitted post-intervention, and also talk about inpatient behavioral facility results pre and post-intervention. Closer look at this chart shows a side-by-side comparison of social determinants of health intervention percentages provided compared to patients readmitted after receiving these interventions. This chart clearly indicates that providing housing, food stability, and interpersonal safety was a huge success. Transportation rates are not surprising given that patients require transport to their destination upon discharge and when readmitted. Closer look at this chart will show you the declining readmission rates at this facility post-discharge intervention. Pre-intervention data indicates that approximately over 223 patients were discharged and 33 were readmitted. These numbers reduced to 15 post-intervention despite the facility discharging over 240 patients. Out of the 50 patients in the social risk group, only 9 patients were readmitted post-intervention. Success of this project can be attributed to strengths such as a high maintenance of patient confidentiality. There was tremendous site and community support. There was no bias regarding patients' age, race, or gender. And the financial impact of this project to this facility due to reduced readmission rates was a motivating factor. The project encountered limitations such as the facility's lack of pre-intervention data specific to the inclusion criteria. Patient diagnosis, non-compliance, and length of hospital stay was also included from the data points. Reliance on nursing documentation of interventions did not rule out the probability of missing data, which was limited to the project. We provide a brief review or discussion of this project's findings and put them into context of this overall project. Starting with the first point, effects of social risk education on psychiatric patient readmission rates. This project's findings indicated that providing nurses with higher awareness and proper social risk education ensured a patient-centered discharge process that improves psych patient outcomes. On providing community resources that fosters effective patient transition, this project indicated that providing this facility with community resources fostered patient transition and empowered the patients to thrive in the community post-hospital stay, which led to reduced readmission rates. On documenting social interventions, um, the project indicated that findings indicated that documenting and providing social interventions to all patients, despite their socioeconomic status, improved their outcomes on readmissions. And taking a look at the final point here, which talks about effects of socioeconomic status on patient psychiatric readmissions. The findings from this project indicated that most patients that were readmitted were single and unemployed, which was indicative of effects of level of education, homelessness, and unemployment to readmission rates of these patients. The consequences during the implementation of this DNP project were high nursing turnover, time constraints, lack of pre-intervention and inclusion data. About 50% of nurses resigned during the implementation of this project. Training new nurses was not anticipated during the planning process. Time constraints required continuous training of new hires, which was time consuming. I'll discuss the project's process measures and outcomes by looking at the quarterly readmission rates, post-interventions, the continuous assessment of nursing care plans, the in-service to address concerns, and the motivation to change. Based on the quarterly readmission data from the facility, a decrease in readmission rates from 14 to 6% post-intervention indicated a positive success of this project. Continuous assessment of nursing care plans is vital for the long-term outcomes of this project. Process measures will continue with nursing education via in-service to ensure compliance. The financial outcomes to the facility due to reduced readmission rates was a great motivating factor for change at this facility. So this slide would discuss the implications of this project to future research. Positive findings of this project was a great start for future research to explore the effects of incorporating social aspects of care with clinical treatment options in a broader healthcare system. Also, effects of adopting social determinants of health-led admission and discharge process in mental health. And finally, determining how social risk tools that track community transition post-discharge can reduce readmission rate. On this slide, I would discuss the implications of this project to nursing practice. A positive outcome of this project ensured health equity by optimizing patient-centered care. A review of Medicaid's current risk adjustments led to reduced penalizations of Medicaid facilities due to reduced readmission rates, and also it could be used as a way of evaluating the effectiveness of core measures by these mental health facilities. Providing social determinants of health screenings in mental hospitals can direct outpatient and community services. It can also support the adoption of social training and practice tools in mental health, and also ensure for advocacy for more supportive social aspects in mental health. I would like to provide a few recommendations based on the outcome of this project. So it is recommended for social needs admission and discharge-led tools and guidelines in mental health institutions to adopt social skills assessment training for the clinical staff and patient to ensure patient-centered care. Also, mental health providers to partner with local organizations and public health to provide community resources that foster patients' discharge process. And also for mental health settings to implement site patient-centered care solutions that are patient-centered. Outcomes of this DNP project, one can conclude that incorporating social care guidelines to clinical mental health care planning reduced readmission rates at this facility. Continuous empowerment of health providers to incorporate social aspects of care in clinical psychiatry changed patient outcomes and improved their transition post-discharge to the community. Therefore, healthcare leaders are encouraged to adopt social guidelines in mental health planning to reduce healthcare demands and contribute to healthcare sustainability. This DNP program at Maryville has been very insightful to my journey as a psych mental health prepared student. The program has taught me my responsibility goes beyond the provider's office. I'm better prepared now to inform patients about the policy issues surrounding their care, and I have the knowledge and ability and power to advocate for improvement in healthcare, and my profession. This is an excellent skill for a psych mental health nurse practitioner, given my patient population and the need to advocate for their care. Thank you for listening, and I am available to answer your questions. And you can contact me through those emails provided here. Have a nice day.